So what happens when a doctor breaks away from traditional medicine and tries what's never been done before in the middle of a pandemic? From parking lot testing to global collaborations, we're exploring the bold moves that our founding physician used to change medicine forever. All of this coming up on The Long Haul with Summer. Welcome to The Long Haul with Summer, a podcast where we're amplifying patient voices, talking about groundbreaking approaches to healthcare, and challenging the limits of traditional medicine. Right now, we'd like to talk to a leader who's done all of those things over the past several years and have helped save many lives and led them to healing, challenging the boundaries and going beyond the guidelines. Dr. Jordan Vaughn. And he is the president and founder of MedHelp and also the founder of the Microvascular Research Foundation. His dedication to listening to patients has really transformed the way that we think about post-viral medication in the last several years. And we want to talk to him today about his journey as a physician and what got him to where we are today. So welcome, Dr. Vaughn.
Thank you for having me, Summer. It's great to see you.
Yeah, we're so excited. So if you could just tell me a little bit about what led you to become a physician and what inspires you to keep doing it.
Yeah, so I mean, in many ways, I grew up in a household where my father was a physician, and so that's a big part of what I saw and really the enjoyment that he had taking care of patients. He was a physician that Dr. Michael Vaughn, who was a little bit outside the mainstream, was on to things like vitamin D in the 80s when everybody thought he was crazy for thinking that it was important.
Yeah.
And also was always somebody that looked at things a little bit more circumspect than the typical physician would in terms of the ways to help people, but also understanding that medicine is a unique enterprise in science. It is really a practice. And in many ways, that means that you're dealing with a human who has both spiritual and physical needs. And it really was a cool thing to be able to apply scientific understanding and cool new ways to help people, but also actually help people themselves. And I think that's very different. Sometimes I think a lot of people think of medicine as, kind of the bench, really applying science and just telling people what to do. But a lot of it is actually talking to people, understanding ideas, learning new things and learning new symptoms, and then trying to put them together to understand what they're going through. And I think that's something, especially in this post-acute COVID kind of world, that is more important than ever. And the reality is there's not a book for this. And instead, what we have to do is listen to patients and actually try to understand what they're going through and explain it in a way what we've learned about anatomy, physiology, pathophysiology, those kind of things. And that really is it's exhausting at the same time that it's fun. I mean, I talk to you and Katie all the time that this is exhausting, but at the same time, it is really fulfilling to be able to almost be, addicted to trying to help people. So.
Yeah, I mean, that's definitely a challenge, I think, with what we're dealing with now. It's interesting that, this started as a family business, and I know that your father's still involved with the practice and everything. And so it sounds like he created kind of the vision that MedHelp was founded on, and you carried that over. Do you think that changed at all, or how did that help when the pandemic came?
So what it allowed during the pandemic was to really look at the data and look at what was going on and really kind of apply what you thought was correct. There, a couple different things. Obviously, looking out for my own employees was one thing. Obviously, there was a ton of fear and unknown that was going on during the pandemic. But at the same time, making correct decisions that weren't necessarily influenced by fear or direction from people telling you have to do this. And instead, what we tried to do was what was right for the patients. So in many ways, even during acute COVID, it was looking at the fact that that actually trying to learn about the disease and actually intervene at different times, whether that was testing in the parking lot to making sure that they got monoclonal antibodies or other treatments really early in their disease processes and preventing them from showing up at the hospital short of breath and unable to really have any other tools at hand because you were so far down the process. But again, that was just the thought was that that's how medicine should be, learning a disease process, intervening. And in a sense, whether that meant exposing yourself to COVID or not, that was just part of the risk you took as somebody that, again, it's probably a bad metaphor, but it's if a fireman was scared of fire, probably not a great fireman. So same kind of concept. If as a physician we're scared of diseases and not willing to come alongside patients and help them in their time of need, it's not really that great of a look for a physician, nor is it really what we were called to do.
Yeah. And so it's interesting hearing you talk about physicians and what we're called to do. So I know, as well as that many physicians and other providers struggled during the pandemic when traditional ways of treating people fell short because this is new. We don't know how to treat it. So what gave you the confidence when those traditional things weren't working to kind of step outside the box and do things against the grain?
Well, the cool thing was at the time, first of all, in really the history of medicine, we've learned that intervening early and understanding a disease process is a lot better than, kind of figuring it out at the back end and dealing with the destruction. But the other thing is at the time, as much as, the connectedness has its own problems, in terms of being able to see what other people are doing and what other people are finding success with. It's a unique time in medicine, really in the last 5 to 7 years, where we have the availability to talk to people throughout all of the world and also find out what they're doing. They're able to publish things even pre-print, get them disseminated to people early, and then the reality is a lot of those things were effective, and it just took the ability and the lack of kind of somebody above you telling you couldn't try it. Obviously, all of this, when you sit down with the patient and make sure they know that you're doing something that, again, informed consent is a huge part of this, but letting them know that, this is why we're doing this. This is what we think is happening. This is what we think is going to help you. And then actually have them say, yeah, let's try it. And that is kind of that patient-physician relationship that allows you to try things that may not be necessarily written down in some book somewhere or some protocol that's disseminated from on high.
Yeah, I mean, I think you're right. We have to listen to patients. We have to come to an agreement. And if they consent, even if you're doing things that are non-traditional, I mean, that's what we can do together as partner. But I'm wondering, did you meet any kind of resistance or adversity?
Yeah, I did. I mean, I think a lot of it was, well, we don't know if that works. And the reality is, yeah, I mean, they were right that we didn't know if it works, but as long as the patient understands what we're doing and there's good kind of validity from you as a physician, and also a lot of the things that we tried and used were things that we knew the safety profile of anyway. So at worst, it didn't do anything, but at best, it actually helped and prevented things that, allowed them to continue to flourish.
So how do you think listening to patients and really forming that relationship during this time was imperative to guiding what you were doing and, or changing what you were doing if something didn't work?
So I think some of it was the most important thing is, and I think Tinsley Harrison probably said that, the most important thing when we talk to patients is the history and it is what they are feeling, what they are seeing, and then applying what our knowledge is of the body, as well as a bunch of other things that we might accumulate, whether it's lab data, imaging data, those kind of things. And then as a physician, trying to make sense of all that to explain a process, and then trying things that we know work to intervene on that process, even though it may have not been written down that this helps in this scenario. If as a physician, you can make those connections and then inform the patient of what you're trying to do, and they're in agreement to try it, I think that's where a lot of these kind of new insights come from. And I think that's one of the things that, especially when you're dealing with kind of long COVID, which is a multi-systems disease process that affects, I mean, and this as well, it's like it's a different story every day, and then trying to make sense of why that's happening. And most importantly, believing the patient that they're not there to tell you something that's not true,
Right.
and instead trying to understand what they're saying and trying to make sense of it medically, and then trying to help them through that. And then that's really where a lot of these clinical discoveries are being made. And I think that's the unique aspect of really even a lot of the people that I work with. It's been really a patient-driven understanding. And the patients, first of all, have a lot of insight into the disease because they're suffering from it.
Mm-hmm.
And amazingly, a lot of them are pretty brilliant and can synthesize a lot of data. So it's been kind of a unique experience to realize that a lot of my insights come from listening to patients and trying to make sense of what they've tried, what they didn't try, what they're feeling, and then trying to kind of give that medical background to it, or that kind of medical information to it, and then try things that intervene to help it, and then having good outcomes. That's, again, I think what clinical medicine really is.
Yeah, I mean, I can personally attest to being listened to as a patient. I mean, I can remember the day I walked in your office with my stacks of papers after all the gaslighting that I had experienced and all the specialists I had seen, to be told that, there's nothing wrong with me. But I appreciated it. Didn't matter what you said. You were just listening to the fact that I was sick. And it's something that I've tried to carry over, as I join the team and take care of people. I mean, just validating what they're saying. And a lot of these people have been through, thousands of dollars of medical bills and treatments, and they've been all over the country. And really what they're really seeking, I think, is just someone to listen and validate, yes, okay, there's something wrong with you. We can work to try to fix it. So I think that is an important part, and certainly something I was not really taught in my traditional training, is to listen and to pay attention, because I think that helps lead us in what we do in taking care of patients. I kind of want to switch gears a little bit. You collaborate with people all over the world. How did that happen? How did that get started during COVID?
So a lot of it was just, again, I mean, now in medicine, I think one of the things that actually the NIH does well is PubMed and a lot of the preprint servers. And so it allows people to put out what they're finding. It may not be peer reviewed yet necessarily, but at least it's suggestive of what they're seeing. And the neat thing about it is they include their name and email. And it's not that big a deal, actually. I think a lot of people find it, you would find that reaching out to authors of papers or different things is a great way to start. And so that's a lot of what we did, which was I would read something. It made a lot of sense to me. I would reach out to the person and ask them, hey, would you mind talking to me and trying to help me understand what you're seeing and how this correlates with what I'm seeing? And then over time, these kind of groups would build. It was almost a natural inertia of people that were interested in helping people. And when you start seeing the same thing and then also kind of adding a little bit of meat to the process, you start to go, man, we may have something here that can help people. And I really think that's how a lot of science is going to be starting to be done, which is one of the kind of, it's very different than what's been done prior to the communication, which was really where a lot of these places were siloed. And the communication, I don't know if it was because of patents or wanting to be discovered or wanting to have their name on a publication, but a lot of these places are opening up to say, hey, we do a lot better when we're talking to a bunch of people. Mm-hmm. We come up with better answers, and we can do this together as opposed to in our little silo. So.
What do you think you've learned the most? I mean, you kind of alluded to that from these relationships that you formed now across the globe about post-viral illness and the way we approach medicine.
So first of all, I think it's that there's tons of people suffering worldwide, and that there's a ton of smart people that are really trying to help folks. The other interesting thing is a lot of the people that are really involved themselves have had issues, which is a terrible way to get interested in something, is when you're affected by it yourself. Not necessarily a terrible way, but it is terrible that they're having to suffer before they say, hey, there's something here.
Right.
And then they have to apply themselves. I mean, some of them are physicians that they themselves were told there's nothing wrong. And then in their own just kind of, hard gumshoe, I'm going to figure this out because I know there's something wrong, they were able to get seen or get to the right people and talked with. I mean, I actually was listening to something from Asad Khan, who's a pulmonologist in England not too long ago, and he was saying that, again, I mean, he was able to finally figure it out, but I mean, he had all the credentials in the world and was still told that there was nothing wrong. Mm-hmm. Again, imagine if you didn't have those credentials and were just going to the physician with your papers and stuff like that. It's again, as a physician, you don't always love having somebody come in with tons of research, but I actually started to enjoy it. And in fact, a lot of the patients sometimes are ahead of me in reading, mainly because they have more time than me sometimes, but it's fascinating to see what they bring in mm-hmm. and what they've already researched. So I really think that is where medicine is going to go, especially in these kind of what we would call infection-associated chronic conditions, which is kind of, again, a name some of these things I feel like are, they're pejoratives because they like to kind of put them in a box and say, hey, we don't know anything about that, so we're going to give it a four letter acronym. But it really is important. I think that's what we're starting to see is a lot of these chronic conditions that were infection associated. Long COVID has given credence to those issues, whether it's Lyme disease or post-viral illnesses like EBV or immune dysfunction that happened after a lot of these things, or even ME/CFS, things that we had always, actually, even in our Western medicine medical education, had been taught, there's not much there. It's probably all in their head. And the reality is it's not.
Mm-hmm. Do you think that these international collaborations will help drive or shape like what's happening in the U.S.?
I think it will, and I think they do. I mean, I think there's actually a recent paper looking at some of the things we look at Mass General that was, again, the product of some of the research that Risha had done in South Africa. So again, her willingness to come over and train people on how to utilize what she had found is driving other places to start looking. And I think that's really cool. That's the way things should be done.
Right. And where do you feel like we stand in the U.S. as compared to other countries on our research and what we're trying to do?
I mean, I think our research is good in some areas. I do think the new leadership, at least with Jay Bhattacharya and Marty McCary, is opening up to understanding that there's something more important than just a paper. There is, how patients respond to treatments, whether those treatments are useful, looking at clinical ways to drive hypotheses upward instead of the NIH driving their thought process downward. Also, the availability of additional medications. I think Marty McCary is opening up the reality that the FDA, in many ways, doesn't always serve the benefit of the patients, and in fact does a lot more to hurt them sometimes in limiting access to things that they should have access to. Mm-hmm. And again, there's a lot of things that go into that in terms of regulatory capture over the years and big pharma and those kind of things. But I think that's changing, and I'm very hopeful for that.
So let me ask you a question, kind of coming off of that. You're in private practice, and so how readily do you feel those resources are available to someone like yourself who's doing grassroots efforts and not in a big major academic medical center?
So they're not historically, and that's one of the things that probably hopefully is being changed. And I think I work with Dr. Robert Redfield, who used to be head of the CDC, and one of the things he found, especially when dealing with things like HIV and AIDS back in the 80s, was private partnerships with clinicians and building consortiums of private physicians was a very effective tool for understanding and treating HIV and AIDS. It needs to be continued to be done with this. And I think that mentality is hopefully changing. The interesting thing is the private world in many ways has more availability to try things sometimes than the academic world. And sometimes the academic world, and even just talking to great academic physicians within their domains, will say, well, that sounds like a great idea, but there's no way I could get that approved. When we, in many ways, in the outpatient clinical private setting, can probably get it approved. Not that it's any less safe or efficacious. It's just that the dynamics of getting certain trials approved, they're just different. So I'm hopeful, and that's really, the government shutdowns kind of postponed it a little bit. We'll hopefully get it back open where we can do it. But I think RFK Jr. as well as Jay Bhattacharya think that it would be great to have parallel pathways of private consortiums of independent physicians to really drive clinical medicine that elucidates pathophysiology that then can be studied at the NIH level. Sometimes that part of medicine has been ignored, and instead a lot of it has been very much, technology, biomarker, single monotherapy intervention driven. And in a illness like long COVID and an illness like Lyme disease, we could hope for a silver bullet, but it's likely not going to be a silver bullet. It's going to be multiple things, and even how people are affected by the same process, the same basket that we put people in for long COVID or Lyme disease, they can have very different responses to very different medications, and but also good responses across that spectrum. And so even like delineating or changing up different phenotypes, which is kind of a way of saying different types of patients suffering from what we would consider the same thing. That's really going to be where clinical medicine comes into play. It's not going to be something you see under the microscope that says, oh, well, this person's definitely going to respond to that therapy, while that other person isn't.
Yeah. And I mean, I know that you were just at the HHS roundtable for long COVID, and I am encouraged that they're asking people from the private sector to even be at the table to have those discussions where you're not, in a major institution, don't necessarily have all the resources, but you have the knowledge taking care of the patients, whether or not it's anecdotal data or not. I mean, it's data.
Yep.
And, oftentimes I can remember, seeing other physicians, outside your care team, and they would say, show me the evidence for this. And I would say, it is me.
Yeah.
I am the evidence. I know your numbers say this, but it doesn't match. But I think that anecdotal data is important, and that also should be considered. The patients, the physicians who are on the front line and providers taking care of these people certainly have things to add. So I feel encouraged that those conversations are happening with people outside of those systems. So I think that's positive. Well, can you share with us, I guess, exactly some new things your team is doing, or maybe stuff that's going on with the foundation that are exciting that maybe we can share?
So one of the things that we've looked at, obviously, we look at a lot of the vascular system, and I think the vascular system and looking at coagulation has been very important. We continue to see that there is changes in the vessels, and especially the lining of the vessels, and then coagulation, which is a fancy word for clotting. And what we continue to kind of research is how those are implicated in a lot of the symptoms that go along with long COVID, from brain fog to shortness of breath to post-exertional malaise. And in addition, one of the things that we looked at was the venous disease aspect, which is a whole part of the vascular system that most of Western medicine doesn't really pay attention to unless it's got a clot in it. But the venous system is really important. It again, takes up 70+% of your blood volume. It is a passive system that's affected by gravity, and it also is involved in refilling your heart. And so what we had found is that a lot of these folks had preload failure, which is a fancy word for saying their right heart wasn't filling appropriately. And so a lot of the symptoms that they were having, which we would have typically thought of as POTS or dysautonomia, and those are descriptions of syndromes, not necessarily, and so it is POTS or it is dysautonomia, but it could be from something like a venous compression or a lack of venous blood getting back to the right heart. And what we found, especially in work with Alexis Cutchins as well as Brooke Spencer, is that in a good bit of these, especially slender, athletic folks, men and women, women primarily prior to COVID were people that suffered from what we would call pelvic venous disease or pelvic venous congestion, that a lot of them are having those issues. And in many ways, anticoagulation and inflammatory stabilization for mast cell activation helps, but also some of them benefit from actually having the big vessel in the pelvis opened. And so that's one of the things that we have been looking at and actually done and are continuing to hopefully get published with Brooke, the outcomes that we've had in those people. Alexis and Brooke recently published something in May. I think it's in the journal Phlebology, but it is looking at how pelvic venous disease and POTS are associated in terms of fixing the pelvic venous disease and ultimately, and specifically iliac vein compression, and how that changes the quality of life measures and patient-reported outcomes in these folks. Again, those aren't necessarily attractive studies to the NIH because, again, getting back to what they love is biomarkers and those kind of things. Right. But, just the quality of life changes in these people and getting blood flow back to their heart, which ultimately means their lungs get good blood flow and their brain gets good blood flow is life-changing to many of these people. And that's really what we need to further understand, but also be able to understand who should get that kind of intervention and who shouldn't. So a lot of this obviously is retrospective, meaning looking at people that we've done it in, in the perfect world of randomized controlled trial, which again is going to be kind of placebo controlled. That's a hard thing to do when you talk about actually doing a procedure versus a sham. So it makes it more difficult to do. It's probably very expensive to do. So right now what we have is really retrospective, and really even getting that information out on our cohort of long COVID patients, which is multiple hundred. I think it's around 400 people that would be in this publication, would be helpful to, again, drive, hopefully, the NIH to say, hey, what is happening to the venous system? What's happening to the veins? And then not only, hey, here's a physical intervention, are there other things that may be non-invasive that we could use to help repair the venous system? So that, again, that's how the crazy thing about this, getting back to listening to patients, is where this came from was listening to patients and their symptoms and trying to explain it. Some of the first people that we actually did this in were extremely athletic people that after COVID couldn't do anything compared to what they used to be able to do. They would get better on some of the medical therapies we did, but they weren't able to get back to the competitive nature they previously were. And that led us to say, well, there's something inhibiting the ability that they used to have. And what we found was it was the fact that there was lack of blood flow getting back to the right heart because of some physical compression in the pelvis.
Yeah. I know that's very exciting, and I've gotten to be involved with those partnerships, and it's exciting that we're having those partnerships now in America where, they've kind of shifted, hopefully, to our own country, and that there are other people like yourself who are also thinking outside the box, stepping outside the box, and willing to work with, other physicians and patients who don't fit the traditional mold. And I think that's great for us to move forward for sure. What about, I know that we are on the cusp of going into our new chronic illness clinic where we're looking at complex chronic diseases, long COVID, yes, but other things. Is there anything you want to say about?
So I think long COVID kind of, in many ways, has opened my eyes to these infection-associated chronic conditions. And for many, again, I think if you were a regular family physician or an internist, you had that patient that was probably a patient that had myriad of things wrong, was allergic to everything, had bad experiences with all kinds of things. In some ways, as a physician, you would think of them as a thorn in your side, but just like on a day-to-day basis, they were the person that really you would say, I don't get that person. I'm not really sure. But the more getting into long COVID and listening to people, the more you see that there's a lot of overlap with, whether it's previous vaccines that they had when they were younger, that all of a sudden they had POTS type symptoms and new allergic reactions to, after I had this infection, all of a sudden I had terrible issues. And it kind of brought this whole new area of people that we had kind of said, hey, here's an antidepressant, hey, go get some exercise. But once you start listening to them and applying a lot of what we've learned about long COVID to their illness, you can find ways to help them. And I think that's where the long COVID part of this is going to be very helpful to people who classically would be called fibromyalgia or ME/CFS or Lyme disease or those kind of things. Because in many ways, they're very Yeah, they're not exactly the same, but a lot of the approach is the same, and looking at them as a whole system and then trying things that intervene on those different areas of the system.
Yeah, I think that's really exciting. Something I've learned from you and the team is root cause analysis. I mean, before I've always been taught and treated as a patient. You have a symptom, you get a pill. You can't breathe, you get an inhaler. But when the first time, I walked into your clinic and you're looking at my whole, every body system and the way it's affected everything, which is the way it should be. And then how do we get to the root cause of that? I think that we've lost that a lot. You talk a little bit about Western medicine, but how are you integrating like other types of medicine into that care that you're giving for those complex illnesses?
Yeah, so I mean, Western medicine exactly, I feel like we become to think of it as here's a symptom, here's a pill. And the reality is the totality of a patient and their experiences and what they eat, what they're exposed to, how their body itself is able to deal with toxins and how it's able to repair itself. All of that matters in the context of things. Mm-hmm. And I think that's what I would look at as a more holistic approach. And I think I'm not totally sure why we threw out that when we think about Western medicine, because to me, the foundation of Western medicine is understanding physiology and then understanding normal physiology and looking at pathophysiology. It's not that different. And in fact, what we need is more of a wide scope. I mean, it doesn't mean we need to throw out any of what Western medicine gives us, because I think it's incredibly important, incredibly helpful. But it also opens up other things that actually can affect a patient's health, whether it is what they eat, how their gut's doing, what are their hormone levels, those kind of things, which we typically kind of throw into the, hey, that's, kind of voodoo medicine. It's not. It's actually involved in how we exist from day to day and every day. And Western medicine, to me, is very good at fixing acute problems to one area. It is not very good at developing strategies to help people for multi-systems diseases and chronic illness states. And in all honesty, some of the even simple interventions we've tried on people, whether it's even just supplements of some sort or changing how they eat or when they eat, has been life-changing for some of these people. And then you go, what the heck was I thinking prior to this, that all this was malarkey? And some of that, I think, is how we're trained. But it also is, it's because of our lack of knowledge about it. So again, as a physician, my father was always somebody who looked at, how you ate, exercise, sun exposure, all those things, which, most people would say, well, what's the point of that? Everybody knows that. The reality is a lot of people don't know that, or at least don't apply it to why they're feeling bad. And I think when you make those connections and people start changing and saying, hey, if I do this, I actually will feel better, it's pretty amazing, the outcome. And then they think you're brilliant, but you're not really. Does that make sense?
Yeah.
It's just like, this is pretty simple stuff.
Yeah.
So.
Yeah, I mean, I definitely was never taught those things in traditional medical education. I mean, yeah, you talk about nutrition, but it's more of a diet plan. It's not about eating clean or healthy or anti-inflammatory or thinking about the way the body can heal itself. And in some ways, like, I feel for myself and for other patients, it's kind of empowering to give that information to them. Like, here are things you can do today to help your body start healing that are not a pill. And a lot of times that's kind of what they're seeking, is some sort of, control over their situation again. And I do feel like it's empowering, but not every provider supports that idea, right? It's always a pill first, in some traditional ways. So I think that's exciting, that we're blending those things and using in a more integrative approach. And the patients are usually receptive to it, and they've already done some of this or looked into some of this.
Yeah, in many ways, some of the stuff, one of my favorite questions is, what have you tried that worked?
Yeah.
And then also, what have you tried that didn't work? And it's amazing, some of the things that I'll be like, well, that's not a bad idea. Yeah. let me see if that actually has some credence. And then when I find, I'm like, well, maybe not next patient, but what I'm saying is, you'd be like, so this actually helped this person, why don't you try it? And then all of a sudden you go, well, it's working.
Right.
Well, maybe there's something there.
Right.
And that's, again, to me is what the foundation of clinical medicine is.
Well, you have to start with N of one somewhere.
Yeah.
I mean, you can't just, have 5,000 people and start doing things. I mean, N of one. And I do learn a lot from my patients too. Like, maybe I should try that for myself and then for other people. So looking back on your journey that's been over the last several years, what is it that you hope that MedHelp and the foundation represents for patients and for healthcare and where we're moving in the future?
Well, to me, I mean, it's really, first of all, helping people and actually meeting the patient where they are, listening to the patient, and then using our best judgment and knowledge to be able to really help the patient heal. The other thing I think is probably overstated in Western medicine is how important physicians are. In some ways, our pills and those kind of things can be helpful, but also the patient themselves understanding the disease process and knowing what can actually heal or help them is in many ways sometimes just as important, because sometimes the biggest problem, and what you probably see this as well, is, oh, you're the first person that's actually validated that I don't feel well.
Right.
And I think that in itself is important. But the actual clinic itself is kind of committed to kind of understanding people and really helping drive innovation through clinical medicine. And so again, that's kind of in some ways, the exact opposite of the way medicine research happens right now. But instead, looking at people having their stories, looking at their symptoms, putting them together with lab data, with imaging data, developing hypotheses, and then driving innovation. And I think that's what we're going to try to continue to do. We've already done it, and I say done it accidentally in some ways, because success breeds more success in many ways because people talk. And a lot of times, the things that we've tried, when they work, great. But people also, when they work, say, hey, I'm better and tell other people. So to me, it's at the foundation, always understanding the patient-physician relationship, learning from the patient, applying knowledge, and then innovating from that patient relationship and knowledge. So.
Now, I know MedHelp as an organization is a large enterprise, but your long COVID team started very small and there were very few people treating it back then. I know our team has grown exponentially, but I still think we're a tiny army. We need a lot of help. So what would you say to providers who are meeting resistance for challenging tradition, but they want to step outside the box? Like, what would you say to them?
So, I mean, in many ways, it's your relationship between the patient and yourself is paramount. Also realizing that it's okay to try things as long as the patient is informed about the benefits and risk of taking something. Applying research to that is important. Reading constantly is also important. I mean, this area blows up. I mean, we obviously throw papers back and forth all the time. I mean, and half of us probably haven't read the paper somebody else sends us because we're all reading. We think we're reading a lot, but we're not reading everything.
Right.
But it's also, and if you really have a commitment to caring for the patient, you've got to make sure that you're set up in a way that allows you to do that without pushback. And that is, in the current system, is hard. And I think it makes it very hard to exist in the independent practice. So, in many ways, it's trying to find out what your core belief is in medicine and how you're going to help people. And if your values don't align with who you're working for, maybe find somebody else to work for.
Yeah, I mean, that's true. I can personally testify to that. And I had a conversation with Dr. Ben Edwards recently, and he was talking about he has, information and guidelines and advice he gives to people who are getting ready to step outside the system and challenge the system, which is hard because, I mean, you're kind of got a target on your back in some ways. You meet a lot of resistance along the way, a lot of questioning and, challenges. But yeah, I mean, I think we have to, go back to that. We're here to help patients, and whatever that means, whatever that looks like, maybe your mission doesn't align with where you are. And that means you have to make a change of scene, which is hard. If you could summarize your philosophy of medicine in one sentence, what would it be?
I mean, to me, it's help. Medicine itself is really a privilege because we get to take care of people who are both physical and spiritual. And that means that it requires care, and we're really called upon to do that. And no one else gets to do that. Meaning the ability to take care of another human being is a privilege that no one else gets. And that's what makes being a provider or physician unique in all other sciences. And to me, medicine is the art and practice of you could say healing, but caring for another individual, hopefully healing, but also sometimes healing isn't always possible, but at least you're caring.
Yeah. No, I mean, I agree. I think that's great. Is there anything else you want to share with our audience about, what we're doing right now and going beyond the guidelines to treat people and just being innovative? Is there anything else you think they need to hear?
No, I mean, I think supporting this kind of effort is important because I think it's going to allow additional research, additional visibility to what's working, and hopefully will drive change in this area. Again, I think a lot of it's just we've been blessed with a state that allows us to do this, but also resources just because of the way my father had set things up to be able to step out and do things for patients that we think's right. So I would continue to want support for that to happen.
Yeah, no, I think that's great. We definitely need that. Like I said, we're tiny but mighty, and definitely need, to rally the troops. So, well, I know you're super busy, so we really appreciate you coming, sharing with all of the people. Many people who hear this are people that you have firsthand touched their lives and led them to healing, including myself. So we thank you for coming today, and we're happy to have you here.
Thank you, Summer. Thank you for having me.
Yeah. Okay. Well, thank you guys for listening in for our very first podcast with the leader of our clinic and our foundation and someone who is transforming healthcare, where we're putting patients first and trying to go beyond the guidelines to help lead to healing. Thank you.